All right, thank you all for going around. I'm Will Sander. I'm also with Booz Allen Hamilton, and we support the Defense Threat Reduction Agency, Cooperative Biological Engagement Program, and I'm a veterinary specialist there and help out with One Health stuff as well too. So, as you all are aware, I'm going to talk a little bit tonight about some stuff that I've done previously. I was once a AAAS fellow as well, and was at EPA at the time in the Office of Water and the Office of Science Technology within Office of Water. And I was specifically working on pharmaceuticals in the water and potential human health impacts. But I'm going to say right now that I am in no way associated with EPA. These are my personal views. This was research I actually did on my own time. This was something I did during my fellowship and not for the EPA. The EPA is very concerned about domestic issues and to a certain extent international issues, but with pharmaceuticals, it's very much a domestic issue in the Safe Drinking Water Act specifically. But I'm going to try and bring some global perspective to this and talk about some of the One Health issues because pharmaceuticals and water probably have a bigger effect on ecology and animals rather than on people. But we'll talk about that as we move through this. So this is what we're going to go through today. We're going to talk a little about the background, why this is important, the occurrence, so how much is out there, what's being detected, the use, so how much pharmaceuticals are being used in various spots around the world, production, how much is being produced, where is it being produced, what are the consequences of that, treatment, so water treatment and how we're trying to get or not get pharmaceuticals out of water treatment for drinking water, specifically for people, possible effects, some regulation that's in place around the world, and then possible future solutions. So this is going to be a pretty rapid speed through a lot of these things, but hopefully give you an idea of what the issue is, because I know some of you in the audience are very aware of this issue, and some of you have very little idea about what's behind all this concern. So try and shed some light. So let's first get a definition of what a pharmaceutical is. I think that's pretty important. So it's a synthetic or natural chemical found in prescription, over-the-counter, or veterinary drugs that provide a beneficial effect and confer benefits to society. So other names that we use out there are EDC for endocrine disrupting chemical. Some pharmaceuticals fall in that class. PPCP, which for those of you who have been looking at the figures at your table, which I'll talk about in a couple minutes, Christian Doughton is the one who came up with those figures, and he's the one who coined this term, pharmaceutical and personal care product, PPCP, back in 1999, when it was still fairly early on looking at the concerns with this in water systems. Drug is obviously another name for pharmaceutical, and then API is active pharmaceutical ingredient. So those are just some terms you might see if you want to dig further into this issue and find out what's going on. So background here, pharmaceuticals have been detected in water since the 70s, but they've really been detected in increasing frequency in the last decade to 2 decades now, especially in developed countries where there's a lot more resources to put towards looking for these drugs. And estimating risk for what could happen with these drugs requires knowing the occurrence, where they're happening, how much is out there, and the chronic effect knowledge, which is really difficult, as we'll talk about as we move through this. As you get exposed to low amounts of pharmaceuticals in the environment, what sort of chronic effects can you have over a long period of time? And it's really complicated because there's 2,000 to 3,000 pharmaceuticals out there that are all, a lot of them fall in different classes, but a lot of them are very different from each other. And to figure out how they work together and interact is a challenge. And they're introduced into the environment through a lot of different ways. Most of the time we talk about human excretion, so urine, defecation, a lot of drugs pass through. Sewage effluent, both from people, but also from production of pharmaceuticals and other sources. Improper drug disposal, so there's a big push back 20, 30 years ago to flush your medication because it's the safest thing. It keeps drugs from getting into the hands of people you don't want drugs to get into. That's not the recommendation now anymore, except for some controlled medications. But really the message is not to flush any drugs anymore down the system. You should dispose of it properly. You should honestly bring it to a take-back program, which there are take-back programs around the US. But the second best option is disposing of it in cat litter or coffee grounds in your garbage and sending it to a landfill. Agricultural runoff, and this is a contentious issue about how much agricultural runoff contributes to this. And obviously plays off with that is livestock and veterinary waste too. So here's that figure that's on your table. And feel free to stop me with any questions. Feel free to get up and get more food, grab a drink. We don't need to hold you hostage. But this is the really complicated figure. Christian Daughton is, as I said, one of the founders or initiators for looking at this issue. And he's a very detail-oriented guy, very smart man, but he also likes to have everything in one spot. So he tried to do that in this figure, which is why I printed out copies, because there's no way you're going to see anything on this screen. But it really addresses all the possible sources, effects, interactions that happen with pharmaceuticals in water, and what potential long-term effects there are. And it highlights issues from wildlife concerns, to human health concerns, to soil and ecology concerns, and tries to point out where there's spots for stewardship, spots to intervene, and then even talk about transformation of the pharmaceutical to something else. So it's a pretty complex chart. I prefer this one from the Government Accountability Office. They tend to simplify things usually. So they did a report back in 2009 trying to look at where pharmaceuticals were coming from in the water system and trying to motivate agencies to come together to work on this issue and make it an interagency problem or concern. So this one here highlights the pharmaceutical manufacturer, talks about municipal water systems, hospitals, talks about wastewater treatment plants, where those municipal and hospital systems go to, agricultural runoff, residential septic systems that potentially leak and get into groundwater and into surface water potentially. And then the receiving end, so you have drinking water treatment plants and going to the tap at the end. And this was all about trying to bring, like I said, agencies together, which I'll talk about at the end, that some of that is occurring. And reports continue to decrease over the last decade as far as pharmaceuticals and how much there is. There was a big story back in 2008 from the Associated Press, which really blew this onto the public attention, looking at several cities, including Philadelphia, and finding a lot of pharmaceuticals. They found about 40-some pharmaceuticals in water at various levels, but it really caught people's attention because most people had no idea that drugs were in your water. They're very small amounts, I assure you, don't worry. Drink your water, it's okay. Ecological effects are not the same as human health effects. We'll talk about some of that. But little is known about mixtures. And this is true across toxicology for the most part. Mixtures are really hard to understand. It's really easy to look at individual chemicals. Same thing with disease processes. It's really easy to look at an individual disease process. You start getting competing chronic diseases in people or animals, or you start getting mixtures of toxic chemicals. It's hard to know how they amplify or don't amplify each other, and how that works. And then treatment facilities, for the most part, are not designed to get rid of pharmaceuticals. They're designed to get rid of bigger concerns like bacteria and other big toxins that we're concerned about. So this cartoon at the bottom here is a guy pouring a glass of water with a picture of his doctor. I don't know why he has it on his desk behind him, saying, "Ask your doctor if tap water is right for you." So the big causes for concern are, as we talked about, endocrine disrupting chemicals. So endocrine disruption is certainly a possibility, especially at even low levels, potentially. Antibiotic resistance, it's a hot topic now for sure. And so at a low level, if things are exposed to antibiotics at a low level, there's possible evidence that could set up for resistance down the road. Sensitization, so again, the argument that low amounts of a certain chemical, repeated low amounts over time, when they're actually exposed to a larger amount, you're sensitized to it and you can have a bigger reaction. So potentially more adverse side effects. Is there a therapeutic effect? What's the level of therapeutic effect that you get in drugs and water? And sensitive populations, obviously pregnant women, elderly, immune compromised, all these folks who potentially are more at risk. So when I was doing some of my research, these are some of the reports I looked at. There's a lot of reports out there, and most of this work was done back in 2014. So I'm sure there's even more reports since then. But these are some of the big ones that I looked at internationally. So again, I was looking outside of the US generally for this research. So occurrence. So current measurement limit for looking for pharmaceuticals is between 1 and 10 nanograms per liter, which is a pretty small amount. But there's a lot of drugs that we know occur at even smaller amounts and potentially still have effects. And we've only developed methods for about 200 to 300 of those 2,000 to 3,000 drugs that are out there to look for it in the environment that are consistent and repeatable and actually have some good data behind them. So there have been spot reports of, within the European Union, carbamazepine, which is an anticonvulsant, at levels above 3 milligrams per liter in certain locations. This is not ubiquitous by any stretch. That's a pretty high amount, pretty high concentration. And EU, which is one of the more progressive developed areas in the world as far as looking for this. They've looked at a lot of surface water because they have a lot of countries that funnel into each other with the same river systems. But groundwater bodies, they still only have about 45% of those measured for a lot of these drugs. And so it's hard to know what the risk is if you don't know the occurrence. For the WHO, they did a report, and it was mostly just a literature review. And their concentrations that they found across the literature were less than 0.1 micrograms per liter. So still very small amounts. And 15 to 25 pharmaceuticals were kind of consistently detected in treating drinking water worldwide. Netherlands is probably one of the most progressive places. They have several systems in place for looking at this and have a huge, again, because Netherlands is surrounded by a lot of other countries and they're very concerned about their water reuse issues, they've looked at this extensively. And again, they don't, from their data, have any concerns about human exposure to this. It's more, again, ecological and animal exposure, potentially. Hospital effluent is one of the biggest point sources, but it's still less than 10% of the total of what gets put out there. So people say, well, let's target hospitals. Let's work on their systems. Well, that's not necessarily the best solution because it's still leaving out 90% of where pharmaceuticals are coming from. And values are pretty similar between the developed countries, at least in the Western developed countries. And Australia has some guidelines. They're one of the few countries out there that actually put out guidelines for what should be an acceptable level of pharmaceuticals in their water for about 80 drugs. And these drugs here listed, alprazolam, Valium, and some estrogenic compounds are close to those guideline levels, but none of them actually exceed them. And again, Australia is more aggressive about this too because they also do a lot of water reuse because of their water concerns there. So I just thought I'd show these couple tables. The first one is excretion rates for certain drugs, just to give you an idea of how much parent compound goes through and how much you might be wasting by going to the drugstore. But you know, things like atenolol, 90% of the parent compound passes through your urine on the other end. So not much of that actually gets picked up and used. But it's pretty variable. And that's a big thing to think about when we're thinking about what drugs to target and how to go about preventing this from getting into the environment. And then the bottom table is concentrations of selected pharmaceuticals found in European surface waters. And all these are in nanograms per liter. So even the biggest one, which is the maximum for, say, diclofenac is 1,200, but that's still only 1.2 micrograms per liter. So it looks big, but it's still not that big. And these are some concentrations across the United Kingdom as well. So again, some of the biggest ones on here, just to highlight some of these, is ibuprofen, which you might assume. But again, the maximum there is 27 micrograms per liter. So we're still not even close to milligrams per liter as far as dose. But still concerning that we have this detection. So we get to mixtures and what's the big deal with mixtures? So, I mean, total toxicity for some studies that people have looked at for antibiotic mixtures can actually be up to 5 times higher than the sum of those toxicities. So it's actually almost a multiplicative effect rather than just an additive effect. And they may be synergistic. They may have suppression on each other when you mix these chemicals together. So it's hard to know which ones to be concerned about as they interact with other drugs in the water, they interact with other chemicals in the water, interact with pH in the water, wherever they're going out into. So there's a lot of factors that play into this. And then how they're changed when they go through wastewater treatment plants, when they go through drinking water treatment plants, they're oftentimes changed as well by the chemicals used there. And then you can have independent action as well. So it's really kind of a difficult thing to try and tease out. The use, let's talk about use, because this is going to drive a lot of our concerns, I think, moving forward. A lot of the developed countries are aging. So in Germany, there are 2,900 pharmaceutical substances and 30,000 tons administered annually in Germany alone of pharmaceuticals. Per capita consumption is increasing due to increasing age in Europe, true in Australia, true in the US as well. And the average geriatric patient in EU receives 7 to 10 different medications per day. So that's pretty staggering in and of itself as well. And as we talked about, the principal sources are hospitals, extended care facilities, but then we also talk about private households play a significant role. And the sources of animal husbandry operations, all the sources that we've talked about in the past for concerns about fertilizer and antibiotic resistance, same here as well. So manure storage lagoons, manure fertilization, runoff from fields, these are all big issues. And there's wide ranges for what agriculture is contributing to this. So the Union of Concerned Scientists says 30% of all the pharmaceuticals that are out in the environment, or the antibiotics, I should say, are coming from livestock. The Institute of Medicine says 70%. So it's a pretty wide range. Some of that's driven by science, some of that's driven by politics, but it's something that still it's hard to tease out. So trying to say, well, let's target livestock or agriculture or target hospitals, it's a much more complex situation than that. So let me just pull this up. So this is the Battle of the Bulge. This is a graph that's shown for a lot of public health concerns, but this is just showing the aging population from 1950 to 2010 to 2050. So you can see at the top on the y-axis we have age, so 100 years old is at the top, and then we have across the x-axis the percentage of the population that falls into that class. So you can just see that bulge of the older population growing here. And this is again from the EU. And then finally, the Stockholm Risk Classification Scheme for prescribers, which I'm going to talk about a little bit more, is actually an idea to get ahead of the game. So having a booklet that physicians can look at or nurse practitioners can look at and say, hey, this drug has this amount of risk potentially. What are some alternative drugs that could still be effective for helping the patient, but might have less environmental impact? We'll get past this fun zoom in. So this is that Stockholm classification that I talked about. So across, we have the substance listed, and it's listed by the anatomical classification system, the International Anatomical Therapeutic Classification System. So this is under the anti-infectives for trimethoprim, erythromycin, amoxicillin, and ofloxacin. And then we have a risk written down in just kind of a subjective term. So whether it's insignificant, moderate, so on and so forth. And then they break it apart by persistence, bioaccumulation, and toxicity based on the studies that they have out there for these drugs, and try and combine that into a score, a PBT score. And that gives them a kind of a ranking of where these drugs fall and what alternatives that are in the same class might be useful for these physicians or other prescribers to consider. And then in the final column, they actually have a volume of sales by prescriptions to hospitals. And this is, again, only in Stockholm County within Sweden. So it's not Sweden, writ large. It's actually just Stockholm County. But it's a good first attempt, and something that I think is trying to be expanded within Sweden. But again, some of the toxicity data is still unknown. So some of these actually have like asterisks by them. Ofloxacin, for example, next to bioaccumulation has an asterisk by it because this is their best guess. This isn't, it's based on some assumptions. So let's talk about production a little bit. We talked a little bit about how much Germany produces, 30,000 tons a year. So with production, there's some environmental risk assessment that happens, especially in the more recent drugs that come out there. This wasn't always the case, but so the EU has implemented environmental risk assessment criteria. So if the expected environmental concentration is above 0.01 milligrams per liter, so that's 10 micrograms per liter, then there should be an environmental risk assessment. But there's no clause in the EU that says that if it's above that and there is risk associated with it, that they can't sell it. So it's, again, a guideline more than really a regulation, but it's out there. On the veterinary side, there's a little more teeth to it. Again, if it's a concentration over 1 milligram per liter, they can actually bar them from selling it across the EU. Some of the other things to consider with production are focusing on benign by design. It's a hot topic, hot word out there. So better chemistry. So reducing the waste, basically, you're making when you produce drugs, because there's a lot of waste that happens. So improving that ratio. And the international classification, as I mentioned, is the Anatomical Therapeutic Chemical Code. And this is really useful for comparing between countries where drugs fall. So this is a quick bar graph here of the number of new chemical or biological entities in the last 2 decades, broken out by Europe, US, Japan, and then other countries. And as you can see, it slowly declines over the, there's less new drugs coming out all the time. But these newer drugs are put to a little bit higher litmus test, at least. So let's talk a little about regulation, what's out there. As we talked about, there's this directive from the EU, the Water Framework Directive, that's looking at what chemicals can be banned. And there are no pharmaceuticals on that list. There have been proposals put forward to put some pharmaceuticals on that list, but so far, none of them have been added, at least as far as a couple of years ago. I didn't check it right before this talk to see if there was something more recent. But things like carbamazepine, which as we've shown some of the other ones, it's been used for a long time. It's been out there for decades. It's been used pretty ubiquitously, is out there in a lot of places and shows up quite frequently. Diclofenac, which I'll talk a little bit more about the environmental impacts. And we actually had Carol Matire speak to this 2 or 3 years ago, specifically about diclofenac, sulfamethoxazole, an antibiotic. And there's a recommendation to add diclofenac and ethinyl estradiol, which I'll talk about some of the environmental effects from ethinyl estradiol, which is the most common component in most daily birth control. In the U.S., the biggest concern, the EPA mostly looks at the Safe Drinking Water Act, and they have 2 mechanisms for placing chemicals on that list that they are concerned about. Not actually regulating against, but concerned about. One of them is the contaminant candidate list, which comes out every 5 years, and they can elect certain chemicals to put on that and look and see what sort of effects that can have and how frequently is that showing up on utilities. And they also have the unregulated contaminant monitoring rule. So those are 2 ways to try and help utilities look for this more frequently and see what sort of occurrence is happening out there. The CCL3, yeah, sorry.
How come erythromycin was included on that list?
How come it was included? I don't actually know why it was included. I don't know the reason behind why that was included on CCL3. And I don't know that it's on the CCL4 that's come out, but I know CCL3 that was included in steroid hormones. And again, none of these are up for regulation, but they are something that they're looking at for. And it is a big deal to get on the contaminant candidate list. But I don't know why it was specifically added. And WHO has issued several guidelines. So they did that literature review that I talked about. And they basically said, after looking at risk assessments, they said, you know what, we don't need to develop guidelines for this. We have bigger fish to fry. They're still concerned about safe drinking water from bacteria and other concerns in a lot of countries that they have guidance in. So they decided there weren't guideline values needed at this point for pharmaceuticals. It's lower on their priority list. And as I mentioned, Australia does have some published guidelines, and they're probably they're farthest along as far as having some guidelines out there to compare against. So effects. We talked about all this background. Let's talk about what can happen. Environmental health effects can be quite different between what happens for people and what happens in the ecosystem. And the big reason is exposure time, right? So people generally drink about 2 to 3 liters of water a day, whereas a lot of animals or plants are in it 24 hours a day. So it's a very different exposure rate. That's the biggest reason behind that. The human health effects. So there's these 2 terms, ADI and MTD. ADI is the, my goodness, I'm blinking out. Sorry? Yeah. Yes. Totally blanking out. Anyway, it's for the veterinary side. I apologize for that. It's the veterinary side, and this is set by the FAO and WHO as far as acceptable daily intake of acceptable daily intake of what can be taken in for drugs and what the points of departure are. So once you reach that level, that's the point that you get concerned about. On the human side, we look more at minimum therapeutic dose and what that is. And that's a pretty conservative estimate by most people's estimates as far as what you should be taking in. And these are often done by controlled studies and pre-selected populations. So they don't really reflect sensitive populations. They don't reflect a lot of the variances that happen out there in the real world. And they also have these toxicology points of departure. So no observed adverse effect level versus lowest observed adverse effect level. And these are common terms you see in toxicology. And these are also ways to look at what sort of effects you can have in a population, not just in pharmaceuticals, but other toxins. And there's different standards of weight and water consumption that are used for what people take in. So the EU uses 60 kilogram person. The US uses a 70 kilogram person. I'll let you guys decide what's appropriate for the US. And there's a lot of talk about being more conservative and using 3 liters of water intake per day rather than 2 liters of water intake per day. And then we also then throw in a fudge factor, this uncertainty or safety factor that we use to try and take into account the sensitive populations or the interactions with other things in the environment. We're not knowing the exact toxicity point of departure. And these can be up to 1,000 times safety factors. So we're dividing out what the level can be by that. So let's talk about some concrete examples of environmental health effects. So ethinyl estradiol is actually, as I said, one of the most common hormones out there because it's used in birth control. And there's a lot of talk about feminization of male fish. Well, it's actually true in some quite a number of finfish. Concentrations as low as a few nanograms per liter can actually cause feminization of some finfish species. And they seem to be the most sensitive aquatic organism. So this bar graph here actually shows controlled fish population here, and these I think are Danios. So the controls are about 50-50, male and female. Again, males are the lighter green, females are the darker green. But even at levels of 0.5 nanograms per liter that they're exposed to, we see a significant difference between the feminization here. So quite a number more fish develop female gonads rather than male gonads. And as we increase the concentration up to 23 nanograms per liter, which is still a very small amount, we actually get some non-differentiation. So some fish never actually differentiate because of their exposure to the hormones. So again, this is an extreme example, and obviously they're a very sensitive group of animals, but it's something to certainly keep in mind. Diclofenac is another big one. So diclofenac is an anti-inflammatory, and it's used quite a bit around the world, but it's in India, it was introduced in the 1990s as a way to use in cows. Cows are sacred there in most parts of India, often aren't eaten, often go to old age and develop arthritis. People want to make sure that they stay comfortable because they're revered. So they were starting to give them diclofenac to control their pain. Fortunately, nobody ever eats the cows. They die naturally, and the vultures that are in the area start scavenging on them. Fortunately, the group of genus of vultures that are there are a bit sensitive to diclofenac. So 97% loss of 3 species of gyps vultures happened in the last 15 years. Tens of millions of vultures. And this is, it's a unique sort of situation. None of the vultures or other raptor species in the US are sensitive to diclofenac. A lot of other places are not sensitive either. They started using diclofenac more recently in Spain. Unfortunately, they have some gyps vultures there too. And so they're starting to see the same sort of occurrence. So meloxicam, they did some testing and found meloxicam, another anti-inflammatory, is safe for vultures and good for the cows. But there's still a lot of black market production of diclofenac, and so it's really hard to get it out of the system. So we're still seeing a lot of vulture loss across South Asia. And then the environmental impact of manufacturing, a kilogram of pharmaceuticals is quite a bit greater than most chemical production for other chemicals that are out there. So it's something else to think about. So we also have these additional possible effects. So degradation products, as I mentioned, metabolism. We have wastewater treatment plants, drinking water treatment plants, what happens in the environment, mixture effects from non-detectable pharmaceuticals. We talked about the ethinyl estradiol at such a low level. That's about the lowest level they can detect it at. And it's still showing effects. Can we go lower than that and still have effects in certain species? And then unknown disposition. So these drugs start accumulating in the food chain. What can sort of happen there? And then chemotherapeutics obviously have a different toxic profile. They're actually geared to be toxic from the get-go and kill both good and bad cells. So what sort of effects can chemotherapeutics have? And one of the studies out there showed that 95% of pharmaceuticals are not easily biodegradable. They actually take some time to biodegrade or some other intervention to make them break down. And 15% of human pharmaceuticals persist in the water. And WHO did a look across most of the countries that they deal with, and activated sludge is one of the biggest ways to treat wastewater in a lot of other countries. The US, chlorine and chloramine are one of the most common ways to treat wastewater here in the US. And both of those are all right, but they usually remove less than 50% of pharmaceuticals in general. Things like some of these advanced wastewater treatment processes like reverse osmosis and ozonation and activated carbon all do a much better job of removing it. And usually in a combination of 2 or 3 of these together, you get 95 to 100% removal of at least the pharmaceuticals we can measure from water systems. But they cost a lot of money. Places like Singapore have implemented actually for treatment processes for their water, again, because of their water concerns, and they have the money. So they have great results as far as getting pharmaceuticals out of their system, but at what cost? And then another big finding is that detention centers, so just pulling water in from a surface water system before treating it, letting it sit in a retention pool before treating it, actually can help break down things as well. But again, there's a cost with having that in place. So this is hard to see, but this is a chart here about conventional and advanced wastewater treatment processes and the percentage of pharmaceuticals that it removes. The big takeaways here is that there's a pretty wide range for a lot of these, but UV and activated carbon tend to be on the higher range of what we're looking at, and ozone. So obviously there's a lot of gaps. We've talked about a bunch of them already. Environmental behavior of these drugs, what can they do? The definition of threshold values, what point should we be concerned? Increasing and making publicly available occurrence data. So I was one of the papers that I was on, there was a big study put out between USGS and EPA looking at 25 different drinking water treatment plants across the country, from heavy urban areas to more rural areas. We finished that study back in 2013, and we finally got the 9 papers from that released from the Science and Total Environment. And so we looked at pharmaceuticals as one component, but they actually looked at 115 pharmaceuticals, 80 other chemicals of concern, and tried to figure out what the occurrence data was. So getting more things like that out into the public and into science literature is really important. And the problem is there's not a lot of money out there to look at this. And if it's not a guideline or a regulation, there's not going to be money put into it. Utilities aren't going to spend money. They already have tight budgets. They're not going to be looking for this. They're going to look for the whatever E. coli or whatever is going to come through the water system that's going to be a concern before they look for pharmaceuticals. We need to look at long-term exposure risks to low amounts of drugs. Effects of mixtures is a big one. Degradation byproducts, and analytical methods, and trying to standardize those analytical methods because there's a lot of variability out there. So these are some of those guidelines. Yeah.
On the gaps of, you said you looked at all those water treatment plants. Has there been any comparison of like bottled water versus tap water?
So I haven't seen any study specifically that looks at the difference between bottled water and tap water, but that's a good point because a lot of bottled water doesn't go. I know bottled water doesn't. A lot of bottled water doesn't go through any additional treatment. Sometimes even less treatment than some drinking water that's out there. But I don't know if there. I'm sure there have been at least a couple studies, but I am not aware of them. So our study definitely didn't look at that. We were just looking at surface water, drinking water treatment plants. So. And these are the guidelines I mentioned from the Australian guidelines from 2008, if anyone wants to look them up. There's about, as I said, about 80 pharmaceuticals in there, and give you some guidelines of the acceptable daily intake, the drinking water guideline, the margin of exposure, what's considered that margin of exposure should be, and the maximum concentration that they've detected in their water system from their research. So let's talk about a few solutions, and on a happy note. I've kind of tried to prioritize these as far as I think the most useful solutions go. One is having a prioritization scheme. So I think trying to have something like the Stockholm guidelines is really useful. Having a prioritization of what's being produced most, what are people taking the most of, what sort of potency goes along with that, and what's the fate of these drugs? Are they easily degraded in the environment? Do they break down easily with treatment? That sort of thing. Combining those factors would be really useful, obviously. Standardizing analytical methods, I think, is really important. We need to know the occurrence before we can know what to do from there. Identification of the most appropriate threshold values. Again, a very tough task to ask for. Take-back programs, I think, are a big one, and one that I don't think the U.S. does enough of. So Australia has a RUM project, which is, leave it to Australia to name it RUM, but it's returning unused medications is what it stands for. So, and they've had that in place for a little while now. Europe has widespread take-back programs. A lot of the countries in Europe treat them as separate waste, whether they go back to a take-back program in a pharmacy or whether they have a separate collection. And a lot of those are paid for from either pharmaceutical companies or from the actual city or municipality budget. And I think that's a big thing. And there was just actually a county in California, I'm blanking on the county, a couple of years ago that tried to get...
You finished?
Okay. And they actually did implement having pharmaceutical companies pay for remediation or trying to take back these drugs in this California county, and it actually held up in court. So that may signal a wave of change of having pharmaceutical companies have more ownership in this.
The question was, do you have data that shows what happens when you don't have a ROM project, for example,
Sure.
compared to after you've instituted a ROM project?
So I don't think that there is data out there because I don't think take-back programs have been in place long enough to know that answer that I know of. But that's a good point. I mean, obviously, we want to know that it's effective. Why spend the money on it if it's not going to be effective?
Sure, it would be really nice to showcase that to say, hey.
Yeah, I mean, there definitely been studies to show between landfills and even leachates from landfills versus going right into the water system, and the effects of mitigating pharmaceuticals getting into the water system eventually. So that has been shown. So if you're having a take-back program and dispose it properly, even if it's going to a landfill, it's still better than going into the water system. And a lot of times they're burning them instead, which, again, we still don't know exactly all the effects that could happen from the air from that. But it's a good point. Mm-hmm. And all healthcare facilities, I want to bring this last point out, should have policies for correct management of pharmaceutical waste. It's a big one. You should have some sort of policy in place. It's not a regulation, but that would be my proposal. So this is a map of countries in Europe that have where pharmaceuticals are treated as separate waste. And all the blue and purple, they're all collected separately in some form or another. So most of the EU has signed on to that. The last set of solutions here, green pharmacies, I think, is a big one. So this picture up in the upper right here is changing one drug for another. It's still just as effective, same class, but it's now 70% biodegradable, whereas before it was 0% biodegradable. So that's a big change. The environmental hazardous classification that we talked about for physicians or other prescribers, veterinarians, would be useful as well, I think, if we can get something like that out there to try and provide some other alternatives. Communication, making people aware of the issue. Wastewater treatment, I think this one's a question mark for me because there's a lot of costs to go along with it. We don't know how effective it is all the time. Most utilities are in a pretty tight budget, trying to put in some new treatment modality, I think it's better to treat something upstream. Take the public health approach, go upstream from that would be more useful. Target larger point sources. Again, I think this is lower on my list because the biggest one is hospitals, and that's still a pretty small amount. And the collaboration of public databases. So I want to point out the collaboration point and highlight the U.S. government for being collaborative. So the Pharmaceuticals and Water Interagency Working Group was stood up back in 2011. And it's actually an interagency working group between 8 different agencies across the U.S., which is pretty impressive for an interagency working group. For those of you who work in government, I hope you would agree with that. And it really spans the spectrum from veterinary agricultural side to military side to human health side to the environment side. The EPA is the lead agency on this, and they meet quarterly, and they're trying to work on making sure everybody has the same access to resources and data, and also working on trying to get more standardization across all the agencies for what they're looking at. Things move slowly because it's an interagency work group, but they do meet regularly, and the people who meet with it are very enthusiastic as well. So that was my last slide, contact information. But if anybody has questions, love to hear them. Yes, questions. I'm just going to switch this over. All right, Taylor.
Hey, Will. So just a question about the minimum detectable concentrations. Is there a possibility to do a volume reduction of the water via like a vacuum pump or something to get it to boil without damaging the contents, and then measure and extrapolate? If you take out 90% of water, multiply whatever or divide whatever by 10, to get around that minimum threshold. Has anybody done that? Is that a possibility?
I'm sure someone has done that. I'm not a chemist, obviously, or a toxicologist for that matter. So I don't know for sure, but there's been a lot of work put into that. So USGS has developed a lot of these analytical tools for surface water, and they've got some pretty good scientists there. So I think that's been done. Yep.
My question is about marijuana, and if we anticipate probably that being added to the list, and I'm wondering if the Netherlands has done any work because of their perhaps more free access, and they have guidelines.
Right.
Have you come across that?
I haven't, and Netherlands doesn't actually have guidelines, so they have a lot more monitoring of what's going on. Yes, monitoring. They have a bunch of different monitoring networks, but I did not come across any form of marijuana or anything else listed in reports of drugs. So I don't even know if they have I'm sure they have an analytical technique out there, but I don't know, if they're looking for it. That's a good question. Kevin.
As a possible solution, thinking about low-hanging fruit, what about requiring pharmaceutical companies, manufacturing facilities, to, I don't exactly, again, I'm not a chemist either, but installing some sort of effluent control strategy or whatever, so that at least at the manufacturing source, perhaps implemented.
Yeah, I mean, I think that's a great idea. I think in the U.S. it's going to be really difficult based on how lobbying and policy is made, and where EPA especially sits right now. I mean, I think some of the pushback that you get with stewardship programs, where you get having take-back programs that are pharmaceutical companies are having to pay for, I think that's one way to push on that. If they can push on that end, they may also want to try and respond on the other end too, upstream. So I think that might be one way to go about it. But I agree. I think it would be great to have, push for more green chemistry options, which in some respects they are pushing for because it can reduce the amount of materials they need to make drugs too. So it could be cost effective. But some of the controls on effluents would be great too. Yes, Cookie.
So I'm guessing, I don't know, that most of these measurements were taken either where the effluent's going in or water sources. Do you know how far out measurements have been taken? Like, is it fish keep? I guess I'm thinking like out in the ocean. Like, do you know how far out pharmaceuticals are ranging? I know, I mean, that's biology.
Sure.
Just don't know with other.
So there's a lot of work that's been done in Great Lakes that I know of for sure. And a lot of those measurements are actually done 2 to 3 miles out in Lake Michigan or, Lake Erie, places like that. So it's pretty far out in a lake. I don't know how far out. I don't think that the work has been complete on that at all as far as how far out into the oceans it goes. How currents play a role in that too. Things like that. I'm not sure. But a lot of these measurements are actually not done right at the outflow. A lot of them are actually done a decent amount away, either downstream or out farther in an open surface water body. Yes, Brian.
When we deal with pharmaceutical companies that come in for review through FDA, part and parcel is to ensure we have a safe and effective drug. And many times you're also asking for an environmental assessment. But I think part of this is the awareness of what is that particular assessment, because does it go far enough to understand the issues that you're showing?
Right.
Because I do believe there's a way, if we can enhance that, then when you have a package insert that describes, there's always a recommendation that we could then work with them on as to how do you dispose of this product so that there is a heightened awareness so we can minimize some of the exposures you highlighted tonight. And I think, again, it's like, how do you tell that story and ensure there's education so that they're all hopefully bringing us to the same page, that we do want to prevent an environmental impact like you've highlighted, yet you want the safety and efficacy of that drug to treat a patient or an animal, but you don't want to have an adverse impact down in the environment. So the more that we can heighten awareness of what you've shown, for example, and interventions, hopefully the companies, which are the source of how do you work with them to enhance this and get them to work with us, I think would go a long way.
Yeah, and I think also working with prescribers, which are a lot of the times the gatekeepers too, and that goes to antimicrobial resistance as well. They can all tie together. I think those are great points. And I think the word has gotten out there more about take-back. I mean, how many of you have heard of take-back programs here? Okay, so about half of you, which is better than it was, I'm sure, 5 years ago. So I think there's improvement there. One downside from a controlled drug standpoint, DEA used to do controlled drug take-backs, and they actually discontinued that about a year and a half ago. Which makes it more difficult to get rid of those medications. So the recommendation is going back to flushing it down the toilet, because the controlled drugs, you'd rather take the risk of environmental exposure rather than exposing your kid or somebody else to controlled drugs. But there are take-back programs in many counties out there that happen at least on an annual, if not semi-annual basis too. But yeah, it's getting the word out.
Sometimes we say how to get the word out, and just thinking right now when you said that, it'd be so simple to have something that when you're going literally shopping, people shop every day for food, how nice to have a package insert just to remind you, oh, by the way, when you're taking your drugs that your physician has recommended for you or your veterinarian has recommended for your pet, when you are completing that, if you haven't finished everything, here's the recommended way to dispose of it. It's just how do you get that message out in a variety of ways. I would say we want to embrace everything we can to help educate.
Yeah, and I know, so I can speak for the American Veterinary, well, not for, but I can speak about the American Veterinary Medical Association. They have a pharmaceutical handout sheet that veterinarians get access to on AVMA and hand out. I was in practice for 5 years. I never handed out one of those. I wasn't that as aware of the issue, obviously. And so, there are resources out there, but it's tough, as you said, to make that jump and that gap. Sure.
So you kind of touched on it earlier about the different types of take-back programs and what they do with them. Is there any sort of standard, or do they all kind of vary in how they then dispose of?
I think there is a standard. I'm not sure exactly what the standard is. I think burning is more towards the standard than I don't know what the temperature is or how that goes about them doing that. So, yes.
Yeah, you get to, in the spirit of One Health, the treatment doesn't just disappear things.
No.
There's other chemicals. Think of mass balance. You're changing it chemically, but you're creating something else, or you're going to have a collection of something that you're going to then put somewhere else. Like in the air, take the sulfur out of the scrubbers of the acid rain, but then it goes into a landfill somewhere, and you got a sulfur dump in your. So that's one thing that's not so clear about the treatment and what happens to the things that are pulled out and they're changed, and is there any unintended consequences? That's maybe an easier question. The harder question is supplements. Okay, we're focusing on pharmaceuticals, the regulated products, but the whole supplement market, yikes.
Right. Yep, that's a whole other ball of wax.
I don't want to touch that.
And do you think there's any pushback from veterinarians or medical doctors? Because the recommendation is always to take all of the medication. And so what's the feeling on the consumer that I didn't take all of the medication, and so now I don't want to admit I failed, and but I have to dispose of it, and those kinds of things. I mean,
there's plus some of that stigma, and a lot of people hold on to their drugs for the next time they have a bacterial infection or whatever. Pull it out. That's 3 years expired. It's going to work great. Or save it for their dog Fluffy or whatever. And so that sort of thing happens a lot, and then they move or something. That's when they discard it. So I think there's a lot of factors that play in the social aspect of how this all works too. So I'm getting past that stigma stuff.
It is. I mean, I would hope that our pharmaceutical places that you can bring your drugs back would say, thank you so much, I'm glad you did the smart thing and not berate them.
Well, I just
For not
if
having
they
finished
went back to
taking
the
their dosage.
doctor.
Yeah.
No, I think
That's why I think take-back programs and pharmacies and your county sheriff's office or wherever they're doing take-back programs is a lot better for most people to get past that hurdle. There's not really a stigma associated with you can take all your drugs sort of thing. Yeah, Francesca.
So just to put things into perspective, we're talking about the US, Europe, Australia, but in most of the developing world, you can get any pharmaceutical in the corner without any prescription, without any regulation.
Mm.
So yeah, in my mother's drawer, I can find things that are 10 years old. And, so it's, just to keep things.
Yeah, I think it gets back to the WHO report too, that they're more concerned about bigger water drinking issues in most of these developing countries, and obviously, as you said, everything over there is over the counter rather than prescription. So, that concern.
it's when they tie it back in to show that now you have an impact on public health. Then they'll pick up and pay attention. And I think it's just a question, as you said, of getting that documentation to finally knock that home, and then there's some heightened awareness that we do want to work together to minimize that additional harm that they had the stigma thought of before.
Yeah, I think right now there isn't any documented public health impact on this. So, unfortunately, we don't want to wait for it to get to that tipping point.
So take your example of the Sentinel, which is your vulture, for example, of here's what can happen. So guess what? What's happening to us when we're being exposed to potentially increased dosages?
Sure. Tanya, do you have a question?
I was just going to reiterate it takes us on a different topic, but the idea of these analytical methods are so very important. You cannot regulate until you have an analytical method that you can implement that doesn't cause excessive burden to the utilities and that it has a benefit to society. So you must have analytical methods. So a lot of times the limiting factor to all of these regulations is the analytical method. So for those that are in academia, it may not be the sexy science, but it is definitely a needed science.
Tracy, did you have a question?
Well, I was just thinking when we're talking about like estrogens and stuff, I mean, there have been public health impacts with early puberty in children because of the estrogen in the milk and everything. So I don't think you have to go too far
when you're talking about water, it may be much smaller amounts, but I don't know that are any tox studies being done, just giving lab animals over a long period of time, not a month trial, to see if anything happens, because that's the only way you're going to find out is if you do the path studies and do the tox studies. But I think most studies aren't of that duration.
Not usually.
So I don't know that we'll ever get that data.
Right. And also finding the species that's going to, humans are one of the longest lived species out there that we get concerned about at least. And, reptiles, things like that, or some fish, whatever. But, it's hard to find, a lot of mice, rat studies are, 2 years, you got 3 years. So.
Well, whales.
Yes.
They found the beluga whales in the St. Lawrence estuary had transitional cell carcinoma, and it was related to polycystic, polychromatic, PAHs, the hydrocarbons from a smelting plant. But there are some wildlife species that are long-lived and are sort of index species. But again, we get no information on whales because they just rot. By the time they make it to the shore, you can't get any decent information on them. So I'm not quite sure where we're going to get this information.
I was just going to add to that, it's not perfect, but the other sentinel that we can look at are oftentimes our pets, and an example by that, the retriever project that we're doing, just to follow golden retrievers from birth to death. As a sentinel in your home, looks at the environmental impact that they've had that entire life cycle. So it goes beyond your small mouse and rat life to having something that's a little bit better. It's in between, but it's better than nothing. And I think it's one way that we might glean some information, because they're looking at them right now across the United States. So you might have a variety of geographic locations, and again, what would be their exposure. But at least it's another way of gathering some data, and we can take a look at it.
Well, I was just thinking about a comparison between two cities, one that has an urban zoo and one that doesn't. Because if you think about the concentrations of some of these drugs and some of the wildlife species, that's a pretty powerful tool to compare from a human population risk perspective.
Mm-hmm. Go.
You talked earlier about the amount of time that an animal is exposed to drugs, and you mentioned the zebrafish. Is that an area that's, you're in the water all the time, you're looking at those in the water? Is that something that's being pursued?
Yeah, so that's what a lot of the research is done in Danio's zebrafish, and that's a common lab species to look at for aquatic toxin effects. So that work has definitely been done in that fish for a lot of drugs.
Who's doing that?
So it's a wide range. Academicians are doing it, USGS is doing it, EPA a little bit in their Office of Research and Development, and lots of other groups, international groups beyond that, are doing it too. So it's a pretty wide smattering of folks. It's definitely one of the most common species chosen for aquatic tox studies.
It's a great presentation for us to highlight the role that EPA plays and why they have to be sustained.
EPA is important. Tracy, you have one more comment?
Not pharmaceutical. Well, I guess it is, yes. But I want to take advantage of having an FDI agent here. If botulinum toxin were put into a reservoir, would any of our treatments take care of it, or are we going to have lots of negative?
Dilution factor. You get these threat levels that say, I'm going to put bison in the reservoir above New York City. They reverse calculated how many millions and millions of test tubes have to process bison to contaminate a liter of that water enough to make somebody sick. So there's a lot of factors. Crazy people make a lot of claims that are unfounded, so people get scared of it. So, I'm sure Fort Detrick, the guys that a lot of these studies, they can tell you more about.
Yeah, and put in perspective too, some of the highest, like ibuprofen or carbamazepine, which have some of the higher concentrations, even though the highest concentrations measured out there, a person would have to drink about 2 Olympic swimming pools of water a day to start seeing some effects, get a therapeutic dose from that. So, that's the size, the amount of what we're dealing with in the water systems at this point. If anybody's up for the challenge, I encourage you.
You know that pure thing that you put
on your faucet?
Tap
Yeah.
water? Does that do anything?
It probably does some, and it's activated charcoal in most of those. So yeah, I mean, it's more effective than just most chlorine treatment systems. In that fact, I still, like I said, a lot of these places that get 90 to 100% removal are usually using 2 advanced treatment. So activated charcoal might be one, but they're also using ozone or reverse osmosis or UV on top of that. UV and activated charcoal are often paired together. Yeah.
What about people who put the alkaline water system in their homes? Like, how would that filter out the pharmaceutical effects of drugs?
I don't know that one actually. The alkaline water systems. Yeah, I'm not familiar with it. So,
yeah, it's a new kind of water system.
Okay.
Alkaline.
Okay. Yes.
What about rainwater? I lived in Bermuda for a long time.
Sure.
So people drink rainwater.
Right.
It's collected on the roofs. It goes into
Right.
the cistern. So if your cistern is clean,
Right.
so you're drinking rainwater, is that going to be less contaminated?
From pharmaceuticals, probably. From other things, I'm not so sure. But pharmaceuticals, it probably is. I would say that's probably a fairly effective way to screen for pharmaceuticals. But I'd be concerned a lot of other possible toxins in there. Yeah, exactly. But you're safe there. So. All right. So I'm going to let you guys have a break. If anybody has further questions, you can come approach me afterwards. But feel free to keep talking, have another drink, hang out. There's no push to get you guys out of here. And thank you all for coming.
Real quick, everyone. As a, I guess, house bar, and then the plates and forks. There's a empty table over here. If you could set them there, so that way we can get those cleaned up. We'd really appreciate it. Save us some time tonight.
What about a charge for dinner? Is there a charge for dinner?
Yes.
Your money.
See this one right here.
Sarah right there will take your money.
John McGinn says, create your money.